My name is Kgosi Letlape. I'm an ophthalmologist in private practice in Johannesburg by occupation and a health activist by choice. So I prefer not to be called a health expert. I'm a healthcare professional and an activist. And I'm glad to be in a panel with experts. Now, I think the disclosure would be that I've been consulting to the tobacco industry and been talking to regulators. Professor Rataemane has come on. So maybe, Faris, I should give him the opportunity to speak as a co-chair before I proceed.
Thank you very much. And I just want to thank all the speakers and my co-chair, Faris, for this session. And I think we have a problem that has been outlined by my co-chair of attitude towards tobacco harm reduction in Africa. But it's not just a matter of attitude, but it's also understanding of the problems of continued use of combustible tobacco. But what has also become an issue, and that explains why we have the lineup of speakers that we have, is that there is failure to understand nicotine and its effects on the brain. There are people who understand why some mentally ill patients smoke a lot. They need a nicotine fix, and some people do. But the biological issues relating to nicotine are not understood. So we have a lineup of speakers who are, number one, going to talk about policy issues and approach to policy. Secondly, we have a speaker who will talk about how do advocacy, Prof. Dr. Letlape will speak about the policy issues. And in terms of advocacy, we have another speaker from Nairobi, Kenya. And I'd like my co-chair to introduce the last two speakers and the themes they are addressing and the relevance to this session. Thank you.
Thank you, Solomon, for this introduction. And I think we can give the micro for Jose.
Yeah, I'm an ophthalmologist in private practice in Johannesburg, but I have an interest in harm reduction, and I've been engaging with scientists and experts around tobacco, including the tobacco industry itself. And the last declaration to make is that in beginning of the year, I'm one of 5 commissioners that worked through a grant from the Foundation for a Smoke-Free World to produce a new commission report about reigniting the fight against smoking. And I think what we've seen globally is that there's been an improvement in reducing the number of smokers around the world. Around the late 50s, 60s, the prevalence of smoking in most nations was above 50%. And with the Surgeon General report coming out and there being awareness and more being told about the comorbidities and the lethalness of combustible cigarette, which kill 1 in 2 of its users in their lifetime, you then saw the changes where the smoking prevalence has trended down for most nations. Sadly, we now have more smokers now than we had in 1999, where we had 990 million smokers globally, and today we have 1.1 billion. But the population growth accounts for some of that. We've now seen a stagnation in the decline in the rates of smoking, even in developed nations and in other nations that may have adopted the Framework Convention for Tobacco Control. Now, in terms of regulation in Africa, most of our governments will be informed by what comes from the WHO as a policy framework. Now, the WHO adopted the Framework Convention for Tobacco Control in 2005, and more than 180 countries are signatories to that to date. But what we need to note and understand is that that Framework Convention for Tobacco Control was clearly focused on combustible cigarettes. And the Empower regime that it prescribes is to deal with combustible cigarettes. The nations that are signatories that have adopted those mechanisms are implementing them, have seen a reduction in the prevalence of smoking in their nations. And my country, South Africa, is one of them, of the early adopters. But despite that, we still have about 7 million people that use tobacco at this point in time. But that's greatly reduced from our prevalences that were above 30, 40%, which is now about 17%. Now, why has it stalled? It has stalled because most nations are not adopting all the Empower recommendations, but also because there are people that will not quit. Studies have shown that some people that are diagnosed with cancer will quit for 3 months, and more than half of them will be back to smoking if they are still alive, despite being on treatment. So it's something that is difficult to quit. So the FCTC is a great tool for nations to adopt for combustible cigarettes. Now, the alternatives to combustion have only really come on post-2010 to be popular. Hon Lee, a pharmacist, reinvented the modern e-cigarette in 2003. Now, if you look at it, the Framework Convention was adopted in 2005. And there were no alternatives really to combustible cigarettes except nicotine replacement therapy, which was only in place because of what Professor Michael Russell said in 1979, that smokers smoke for the nicotine, but they die from the tar. And from that statement, nicotine replacement therapy was born. But now we have many other alternatives based on technology that are alternate supplies of nicotine without combustion. Now, here's one thing that most of us need to be aware of. Snus has been used in Sweden for more than 200 years. Snuff has been in our environment for as long as I can remember. But the Framework Convention for Tobacco Control was not even written to be appropriate for the non-combustible tobacco products that were available even prior to 2000. So what happens when we adopt the Framework Convention for Tobacco Control in 2005? We say, ban snus. That was all that was provided, was prohibition for snus. Now, in the last 40 years, the Swedes have collected information on snus use. One of the key tobacco producers, the company in Sweden, decided to forsake combustibles and concentrate on non-combustibles. The result of that is that we have epidemiological evidence from Sweden about the benefits of non-combustion. We all hoping to reduce prevalence of combustibles to 5% or less in our communities. Guess what? The Swedes have accomplished that. They have a prevalence of smoking of around 15, 16%, and only 5% is from combustibles. The other is from non-combustibles. What have they benefited from that? Amongst males, where the use of snus is higher than in females, they show the lowest incidence of disease and morbidity related to tobacco use. Why? Because they've gone to non-combustion. What is the outlook of the WHO on that? Ban snus in Europe. Banning doesn't work. So even though the FCTC is great for combustible cigarettes, there's absolutely nothing for non-combustibles. There was nothing even in 2000 when there were non-combustible products. It has become even more glaring now that there are many more non-combustible products like electronic cigarettes, like heat-not-burn, like pouches that contain nicotine, which are new inventions. And that framework is totally inappropriate to address those. So we need to ensure that our governments in Africa understand that the FCTC is great for dealing with combustible cigarettes, but it's totally inadequate. It was not conceived, and it's not a fault of the WHO. There were no real combustibles. They should be blamed for not having created a framework for non-combustibles of the time. It is now worse because there are more non-combustibles now. So we now need to urge the WHO to come up with a new framework appropriate for the products that are available today. You can't do a cut and paste of the FCTC to the non-combustibles. It just doesn't work, as is shown by the fact that it was wholly inappropriate for products like snus. It's wholly inappropriate for e-cigarettes, heat-not-burn, and the other alternatives that rely on not combusting the tobacco. So we need to advocate for appropriate regulations. And one of the key issues for Africa, cigarettes are cheap. It's to ensure that the regulations that come up don't make alternatives to combustion unaffordable to the ordinary people. Even in first world countries, the vulnerable groups are not liquid. They don't have high economic status. So the issue of access to alternatives is key globally for all vulnerable groups, but paramount in our continent and low to middle income countries. So we need to ensure that we don't hear of anything that bans products just because people are ignorant about them. We need to advocate for appropriate regulation, ensure that smokers can be educated, ensure that the public can be educated, and that the products are readily available and affordable. Misinformation is a major problem. I hope the WHO will learn from the fact that in these days of COVID, they've encouraged governments to rely on science to form regulations. The same thing should be done in tobacco. And I can't not compare the parallels where smoking kills 8 million people a year globally. COVID has killed 4.5 million people in nearly 2 years. Smokers matter. Smokers are human too. So let's encourage our governments to understand that we need to write new regulations based on science, based on relative harms caused by alternative nicotine delivery. I'm a physician. If nicotine was the problem, why would we have accepted nicotine replacement therapy? Lastly, on misinformation, you can see in the COVID pandemic that those that base their approaches not on science are called anti-vaxxers. Vaccines work, but we still have a low uptake in some countries, including mine, because of the misinformation. The irony is that with tobacco, the misinformation is propagated by the WHO, and it's encouraging governments to spread misinformation. In my country, a questionnaire revealed that more than 70 people think that e-cigarettes are more harmful than combustible cigarettes, something that has no truth. So I'm looking forward to the discussion, and I hope we will ensure that our governments understand that FCTC is great for combustibles, but it is not appropriate for anything else that is not based on combustion, including old non-combustibles like snus. Thank you, Faris, and I'm looking forward to a fruitful engagement at the end.
Thank you, Dr. Letlape.